discussing pregnancy and pulmonary hypertension here at the CHEST 2014 conference. Joining us to do that is Dr. Mardi Gomberg-Maitland. Thanks for stopping by.
Thank you for having me.
Pregnancy and pulmonary hypertension, PAH, is a challenging area. How do you approach it day after day?
Yeah, I think I've been fortunate to be able to counsel my patients not to get pregnant because it's such a high risk. It's a high risk for the patient, it's a high risk for the fetus, and quite frankly, we're just not successful. And success is live, healthy child, live, healthy mother. And so even with the advent of new medications, one would think, oh, now that we have all these therapies, we should be able to get patients through pregnancy. But pregnancy in itself, we were taught in medical school, is a disease. Your blood pressure gets affected, your heart rate gets affected, and it puts a tremendous stress on the heart. And that's in somebody who's healthy. And then you take somebody with cardiopulmonary disease and it's just not safe. And so, I really have had the fortune of having long-standing relationships with the patients and really counseling them up front, but not at diagnosis. It's usually as they're feeling better, they think, why not? And then it's, how do you do this? What's the safest way? You can get eggs and you can have them extract, you can have surrogates, and then there's always adoption. And I think that once patients see other patients that have gone through it and have had successful surrogates or adoption, that they realize that it's probably just not worth their risk, that if they're doing well on therapy, they shouldn't get pregnant.
So what did you share in your presentations that your colleagues could take away and maybe use themselves?
Yeah, my presentations focus on the guidelines, which is to avoid pregnancy, but that if some patients, they get pregnant and they want to have the baby. And so how do you manage those patients? First and foremost, you need to be in an expert center because these patients at the end, that last trimester, they really sometimes have to be hospitalized. Sometimes they need additional PAH therapy. There are some therapies that you cannot use with pregnancy, and those need to be stopped early on when you know. And so it's really taking on a whole nother disease process to get them through and understanding those risks. And then what's, I think, the most challenging is that after the baby's delivered, the mother's still at risk because of all the shifts in hemodynamics that come along with pregnancy, that could be the toughest time. And if you're not at a center and you don't have it organized as far as with your obstetricians and your anesthesiologists and your critical care specialists, it's bound to not work out well. And so if you're put in that situation, then you really need to know how to handle it.
How have you been so successful in this area?
I think it's patients want the facts and the evidence. And when you present them with the evidence, which is case series, showing that a third to a half of the moms don't make it, and the babies don't make it, maybe less, but even so, there's a lot we just don't know, that patients realize that it's just not something that they want to do. I think that we've been successful with early elective abortions because they know that it's going to be a risk. But I think it's center dependent and it's physician and patient dependent, and I think we've been lucky.
How have the new treatment options affected the decision-making process?
I think that at least now there are options that we can start patients on continuous infusion, even if it's just in the peripartum period, meaning while they're pregnant and post. And there have been some case reports that that's been successful. But the problem is that irrespective of what we measure in the cath lab in a patient, meaning their hemodynamics, they might look like they would be fine with pregnancy, but until they're under that stress, we can't predict how they're going to behave. So it's comforting to know that we have infusions and we have some oral therapies that seem to be okay with pregnancy, right? There's never enough data to say one way or the other, but still, for me, it's such a high risk that I'm still uneasy with the whole pregnancy and pulmonary hypertension.
Thank you for your time, Dr. Gomberg, and we wish you the best in going forward in this area. It's so important to so many women, as you know, as well as anyone. Thank you and good luck.
Thank you.